90% will die, and 10% those who survive will have significant disability if you don't remove the clot. And as I said, the usual formula, if the clot is big, they don't respond to IV thrombolysis. If it is a small clot, that will respond. Even if wherever it is, they will dissolve. But if it is a big clot, and that's where if there is a big clot, you need thrombectomy, and that is more or less accepted treatment. If you have got a basilar artery thrombus, you thrombolize, and we always take them. Most of the time they don't resolve, and they go to theatre and have thrombectomy. If you don't do in this patient, you have got bad prognosis anyway. And from our experience, some of the patients, not everybody, because by the time you take away the clot, already the damage has happened. So they won't make a spectacular recovery. But some of them, they make spectacular recovery. For example, GCS is 3, 4, 5, had a basilar artery thrombus. You take them out. Next day they might be, awake and with minimal disability. So that has happened. And some of the patients, we have managed to take out the clot, but they were, brainstem dead, or they are locked in. So that can happen as well. But overall, because the prognosis is so poor, if you don't do anything, thrombectomy is the treatment of choice probably. And most of the trial, they don't take thrombectomy for basilar artery anymore, because they know that there is no other option. So they go for they will go as a treatment. For us, it's much easy because we will take them immediately, and that is the best treatment, what we feel. Okay. Are you aware about anything else which can be done apart from thrombolysis and thrombectomy, which can help to dissolve the clot? We are taking part in a trial called Clot Buster. So on top of thrombolysis, in this trial, they receive transcranial Doppler. So there is evidence that if you give Doppler ultrasound to a clot, it causes microfracture and helps the altiplase to penetrate better and helps the clot to dissolve. So that is one of the trial which is going on. Their recruitment is very, very fast. So we will come up with an answer in the next 1 or 1.5 years, whether that is more effective and it is safe or not. So that's something which has been already, the trial is going on. We are taking part in that trial. Okay. So, for example, your patient, he has got AF, okay, and he has come with stroke. How would you manage? You have done a CTA, it has shown that there is infarct. What treatment would you offer? Unfortunately, he has gone out of time window for anything. He hasn't had thrombolysis, he can't have thrombolysis, and already the infarct is established, so even if you take out clot, it won't make any difference. So he hasn't had thrombectomy or anything. So how would you treat him? Okay. When can you put anticoagulant? Straight away?
Not straight away.
Why not?
To prevent hemorrhagic transfusion.
That's right. So the present evidence is we don't put them on anticoagulation straight away. We put them anticoagulation depending on the size of the infarct. If it is a big infarct, like presumably if you have got a pica involvement, it will be a large infarct. In that case, you wait for up to 2 weeks before you start anticoagulation. But while you are waiting for anticoagulation to be started, what else can you give?
Would you give aspirin?
You give aspirin. How much aspirin would you give?
300.
300. Why do you give 300, not 75, not?
Because you can, it's better.
This is based on 2 important trials called CAST and IST, where they use. So only two important trials has been done as an acute. One is called Chinese Acute Stroke Trial, another is called International Stroke Trial. Okay, both of them use high dose, not 75. One is 150 or 160, another 300 or something like that. So that's why we normally use high dose of antiplatelets. Okay. What else can you do? He is not mobile. How would you do thromboprophylaxis on him?
Stockings.
Who would give stockings?
There's not evidence for using them routinely now, is there?
There is no evidence of stockings, plain stocking or TED stocking in stroke patients. There is trial already done, CLOTS trial, which has clearly shown it is ineffective. What else can you give?
Can you give it's like a manual stimulation you use for the legs?
The only evidence which has got, if patients are immobile, you can use foot pump. So you put like a sleeve and then there's a machine which will inflate and deflate it. And it has shown that it reduces the risk of DVTs and PEs and also death from any cause. People don't understand why that is the case. Probably it prevents PE and the clot going, and that's how it does that. But what we will use is foot pump. Okay. What else would you do? What about the blood pressure? What would you do to the blood pressure? His blood pressure, for example, is 210 by 100 or 98. What would you do to the blood pressure?
It's not over 220, so you don't treat it in the acute setting.
In acute setting, why don't you treat it?
You want to keep perfusion up in the brain
Why?
because you can increase collateral perfusion if you've got hypertension.
Why?
Because it's
What
a high
is-
pressure.
Hmm?
Because it's a high pressure, so it's forced.
No. What is autoregulation? Cerebral autoregulation.
You lose a lot of autoregulation because
You
of
lose
thalamic involvement.
Autoregulation. If you lose your autoregulation, that's why if you don't maintain your blood pressure, you can get hypoxia in the brain, and that's why it is not used. What happened if he had a bleed in the cerebellum? What would you do to the blood pressure? Why do you reduce in hemorrhage but not in ischemia?
Because potential the raise massively.
But what happened to autoregulation?
Is it not lost?
In hemorrhage, there is because that is very important to understand. In hemorrhage, autoregulation is not affected, and that is shown in the animal model very clearly. And what does a prognosis in hemorrhage depends on? By the size of the hematoma. Bigger the size of hematoma, bigger is the chance of poor outcome. So how would you stop somebody getting poorer outcome? By making sure that you do everything to not allowing the thrombus to grow bigger. If you have got hypertension, what is the most important predictor for increasing the size of hematoma? Uncontrolled blood pressure is one of the important predictor for increasing. So if you keep the blood pressure high, your hematoma size is going to go up, most likely. But there is a trial done called Interact 2, which clearly shows that if you reduce the blood pressure in hemorrhage quickly, rapidly, that doesn't cause any poor outcome. In fact, it was almost statistically significant to show that it benefits. So, present treatment is to reduce the blood pressure. If you have got a bleed with hypertension, the first thing you do is to bring down the blood pressure as quickly as possible. We use intravenous, for example, labetalol. We use GTN infusion to bring down the blood pressure.
Can you explain autoregulation in ischemia stroke, please?
So normally, for example, between 60 and 150, if it is the systolic blood pressure, and this is the cerebral blood flow. See this curve. You understand what is happening? So between the blood pressure of 60 to 150, your cerebral blood flow always remains more or less constant. Because brain has got a mechanism to. So, for example, if your cerebral, if you have got a major bleed and your blood pressure goes low, even if it goes low to 80, brain has got mechanism to still continue the blood flow in the brain in the optimum range, in spite of the fact that the systemic blood pressure is going low. But there is a limit. If it goes below 60, or it will ultimately, you will get dizzy, or your blood flow will go down. But there is a buffer between 60 and 150. I am saying roughly, the cerebral blood flow remains more or less constant. Okay, it doesn't change. So if your blood pressure is 150, your cerebral blood flow will be more or less same as if it is 80. It doesn't change significantly. Okay. If you have got hypertension, what they say is probably this curve will shift to the right a bit. So you need it will shift to the right. You understand? So if you will need higher pressure to maintain the same level. But what happens in stroke? This autoregulation is completely lost. Especially this is from the large vessel stroke. There is no study done in small vessel stroke in animal model. But large vessel stroke, for example, if the main study was done by tying up the middle cerebral artery in a rat model, for example. And what they showed, this autoregulation is disrupted. And that is subsequently shown in human model as well by doing various scans. And that is where the problem with ischemic stroke managing blood pressure. Okay, and that is where the problem. And so, for example, if you have lost your autoregulation, so what will happen? If your blood pressure goes low, your cerebral blood flow will go down. If your blood pressure on the other end is too high, what will happen?
It will go too high.
It will go too high. Okay, so there is no source of
There's no buffer. Yeah.
buffer. The buffer is lost. Okay. Now, if you have got an area of blood vessels, and the area distal to it, what will happen? If you have got an ischemic stroke, a blockage, the area distal to it, blood flow is reduced. And if you artificially, because the systemic blood pressure has gone up, actually body is trying to increase the blood pressure so that the area distal to it still gets some supply. And if you bring it down, what will happen? They will have more ischemia. And that's the reason why we don't do that. On the other hand, if you have got a ischemic stroke and then you have removed the clot by either thrombectomy or by thrombolysis, what would you do to the blood pressure?
Take it down again.
Yes. Okay. In that case, you want to keep the systolic blood pressure preferably below 60 and diastolic below 90. Because in that case, presumably the autoregulation will come back. And if you keep it too high,
My hemorrhage.
it will cause hemorrhage. Because the blood-brain barrier will be affected, the pressure will increase, and that will cause hemorrhage.
At what point can you give them an antihypertensive?
If, for example, for ischemic stroke, if you are not thrombolizing, I have hardly ever used antihypertensive. Okay. But the only time when it is extremely high, it is very, very rare, 250 by 120, 130, or if they are showing effect of hypertensive encephalopathy, or then only you can use. But that is an extremely rare situation. In fact, some of the people, they go on the other side. So if you have got a ischemic stroke, a big clot, and you are not able to recanalize the vessels for any reason, out of time or etc., they actually artificially increase the blood pressure to allow the surrounding area to have more perfusion. So they will give epinephrine infusion to increase the blood pressure so that the surrounding area, and there is some evidence probably that might improve the outcome. We don't do that in Europe. It's mostly a practice in Canada and North America. Some centers they do. With the assumption that that will keep the penumbra to have more blood flow, thereby improve the outcome. Okay. For us, what we do, we make sure that the blood pressure doesn't go too low. They are properly hydrated. Their electrolytes are maintained, and that's how we try to set the penumbra.
So, can you give antihypertensives to someone that has been thrombolized?
Of course, we have to give.
Okay.
We have to give. When we are thrombolizing somebody, we do give antihypertensive to bring it down before we thrombolize, because what we know with thrombolysis is the other important thing what you might know, that altiplase has got some negative effect on the blood-brain barrier. It damages the blood-brain barrier. And so, if you keep the blood pressure high, if somebody is on altiplase, their blood-brain barrier is more likely to damage because of altiplase, and they are more likely to bleed. Okay, so we bring down the blood pressure and then thrombolize, and also maintain the blood pressure low. Any other question? Did we stop here? Are you two? I've got two.
I can keep going.
Okay. You can keep going. That's fine. I can keep going. Okay. Anybody has taken any more history?